شكرا دكتور أسامة على إتاحة الفرصة لينا في المشاركة في المؤتمر، وشكرا دكتورة سونيا. شكرا يا نور. هنبدأ كيس 2 من الحضانة. كيس 2 من حضانة فؤاد. Male full-term baby, 5 days age, presented with neonatal jaundice. Was history of cough 2 days before admission. There was maternal history of common cold, fever, and cough antenatally 3 days before delivery. Otherwise, there is no significant history in mother. The baby admitted to NICU, put on phototherapy. By examination, there was moderate general condition. The baby was lethargic. There was mild grade fever and mild cough, slow bottle feeding. The second day of admission, the baby developed respiratory distress in the form of tachypnea. He was put on open oxygen, and we started empiric antibiotics, antipyretic, and blood culture was done. Third day of admission, there was more tachypnea and retraction. The baby still feverish. He need to put on CPAP. There is feeding intolerance, diarrhea. We started IV fluid. The next day, the baby was desaturated and more distress on CPAP. There was bad perfusion, mottling, cold extremities. He was shocked. We do an echo. There was right side heart dilatation, severe tricuspid regurg. There was severe pulmonary hypertension, and we started sildenafil. Then the baby need to be ventilated on high parameters, and there was generalized edema, distended abdomen, and palpable liver. By labs, there was elevated liver enzymes, impaired renal function, and elevated inflammatory markers. So what do they think about this case? Is it sepsis, MESI? So what's MESI or MES in neonate? There is no definite definition of MESI in neonate, and according to WHO and CDC, they only discuss presenting in MESI in neonatal period. There's 3 pathways for infection in neonates. Following maternal infection without active infection in neonate, active infection in neonate leading to extrapulmonary multisystem inflammation, post-infectious delayed hyperinflammatory response. So how to diagnose a case of MESI in neonate? First, presence of fever, involvement of 2 or more systems, shock, cardiac, GIT, hematological, and evidence of elevated inflammatory markers such as CRP, prolactin, LDH, interleukin 6. This diagram show what criteria of diagnosis of MESI in neonates: fever, involvement of 2 or more systems, elevated inflammatory markers, and no alternative diagnosis, viral or bacterial infection. These 2 systems affected in the MESI: neurological in the form of seizures, respiratory in the form of distress, pulmonary edema, BPHN, renal in the form of AKI, fever, rash, hematology, thrombocytopenia, leukopenia, anemia, cardiovascular, hypotension, shock, cardiac dysfunction, arrhythmias, coronary dilatation, aneurysm, pericardial effusion, or intracardiac thrombi. Hepatic, liver dysfunction, hepatomegaly, GIT, feeding intolerance, diarrhea, necrotizing enterocolitis, and emesis. So our case meets our criteria of diagnosis. There was fever, yes, involvement of 2 or more systems, cardiac, GIT, hepatic, renal, elevation of inflammatory markers, no proved other diagnosis, blood culture show no growth, and maternal history of infection. There is the labs of our case. CBC was normal, inflammatory markers, the high CRP, elevated LDH and CKMP, D-dimer was very high, elevated liver enzymes, AST and GGT, Create was high. Affection of system, cardiovascular, he was shocked. There was PPHN, pericardial effusion, hepatic elevated liver enzymes, hepatomegaly, and by ultrasound picture of acute hepatitis, renal, impaired renal function, and anuria. Imaging, chest x-ray saw bilateral lung opacification. By echo, there were pericardial effusion, right-sided dilatation, and PPHN, and also coronary and artery ectasia. By abdominal ultrasound, there was picture of acute hepatitis and non-calcular cholecystitis. So how to manage case of MESI? Supportive management with respiratory and hemodynamic support, IVIG, methylprednisolone in the dose of 1 milligram per kg every 12 hours. And if the baby needs vasoactive inotropic support and has ventricular dysfunction, he needs higher dose of methylprednisolone, 10 to 20 milligram per kg per day, in 2 divided doses on the first day, then followed by 1 milligram per kg per dose every 12 hours. So how we manage our case? By hemodynamic support, IV fluid, by TPN, plasma transfusion, antibiotic. We started antibiotics before we are sure of the diagnosis. We started vancomycin and meronam and show no response. The baby is still feverish. We started sildenafil at first when we diagnosed PPHN. It was not effective. The baby is still PPHN. And he was feeding intolerant, so he can tolerate the sildenafil. We started dopamine as an inotropic at first. He was in tachyarrhythmias, so we stopped dopamine. We started Primacor and noradrenaline as the pulmonary pressure was very high, 90 millimeter mercury. We started Lasix IV as the baby was in generalized edema. We gave IVIG in dose of 2 gram per kg. He showed no response at first. He's still feverish, bad general condition. We started pulse dose of solimidrol, 10 milligram per kg, as there was cardiac dysfunction. Then we shifted to dose 1 milligram per kg for 5 days. We gave low dose aspirin in the dose of 3 milligram per kg, as was their coronary affection. And this is a case series on neonatal multisystem inflammatory syndrome after maternal infection. It shows system affected, cardiac affection in 90% of cases, thrombosis and hematological affection, respiratory affection in 55% of cases, GIT affection, neurological affection in 30%, cutaneous affection in 10% of cases, renal affection in 5% of cases, and fever, temperature instability in 5% of cases. Cardiac function finding in the form of arrhythmias, dilated coronaries, intracardiac thrombi, shock, and cardiac dysfunction. The therapy used in this case series, they use steroids in 100% of cases in the form of methylprednisolone, dose 2 milligram per kg per day. They use IVIG in 100% of cases in dose of 1 to 2 gram per kg. They use low molecular weight heparin in 70% of cases, a dose of 1.5 milligram per kg per dose. They use inotropes in the form of milrinone, adrenaline, dobutamine, dopamine. The outcome in this case series, mortality in 10% of cases due to necrotizing enterocolitis and multi-organ dysfunction. So to summarize the case, according to the reported data from CDC, there is only 4% of total MESI cases in infants below 1 year. Most neonatal MESI data are from case reports and series. ودي كانت مشكلة عندنا ان احنا ما كانش في بروتوكول لعلاج الميسي في النيونيتس according to the guidelines اللي احنا بنشتغل عليها. ودكتورة نورة مشكورة تواصلنا مع دكاترة الجامعة ودخلنا بروتوكول للميسي واعتمدناه في الحضانة. الميسي in neonate, although it's rare, it's associated with high morbidity and mortality. Messi in neonates may present with wide variety of signs and symptoms, عشان كده ممكن نتلخبط في الدايجنوزس بتاعهم. So early recognition and management is important and life-saving. The combination of IVIG and methylprednisolone versus IVIG alone was associated with better outcome, وده اللي حصل في الحالة اللي عندنا. We started IVIG first with no response. Then we started pulse therapy with dramatic response. The outcome and follow-up in our baby improved soon after pulse therapy, extubated to CPAP. There was better perfusion. The fever subsided. He tolerated feeding gradually. Urine output back to normal. It was better activity. By echo, improved function, normal pulmonary pressure, weaned from oxygen and cardiac support after 5 days of therapy. He followed coronary size outpatient in echo clinic, and that is the end. Thank you.
شكرا جزيلا دكتورة أسماء.
شركة مونو ميديا ترجو لكم دوام المناسبات السعيدة.